Thank you very much for the organizers for giving me this opportunity. I mean, yeah, unfortunately, the topic is too specific. I could have actually finished my talk in, one slide. Yeah, surgery is the treatment of choice following neoadjuvant chemotherapy if resectable, and if not resectable, I would send to my radiation colleagues for CTRT. Yeah, but yes, I've been given 10 minutes. Let me see what I can do. So, pros and cons. The first question that comes to mind is, are we doing a safe surgery after neoadjuvant chemotherapy? Is restaging required after neoadjuvant in terms of mediastinal? I'm a surgeon, so I would talk in terms of mediastinal. And I'm more fascinated by doing minimal invasive. So is it really feasible after neoadjuvant chemotherapy? And is it oncologically safe? I think this has been covered by my colleagues. And what is the extent of surgery? Can I draw boundaries? Is what following neoadjuvant chemotherapy. So yeah, this has been discussed, so I will not get into it. Increased operability, you're trying to prevent better tolerability, all those. Cons, again, progression, delay in surgery. Is there any, chances of post-surgical complications may be slightly higher? This is something which is important. So first thing is surgery safe. There are no randomized controlled trials which actually really looked up at this, but you have trials which looked at surgery versus neoadjuvant chemotherapy followed by surgery. These were the older trials. So you don't have one-on-one comparison between adjuvant surgery followed by adjuvant. So the morbidity, you take it from the neoadjuvant groups, they are more or less similar. And overall mortality also remained the same. But if you see, wherever there were pneumonectomies done, the mortality was much higher when compared to lobectomies. If you're going with a lobectomy, then the mortality also remained the same. And most importantly, the right-sided pneumonectomies had much more mortality when compared to the left-side pneumonectomies. And the morbidity was more or less equal in both the groups. So surgery is a safe procedure. The most common morbidity being atrial fibrillation and pneumonia, which is the most common, atelectasis, collapse, and pneumonia. So there's no difference that neoadjuvant chemotherapy is not going to hamper or increase the morbidity and mortality of a patient following surgery. Next, do I need to restage? So this is one policy which has not been very followed because this is an area of debate. So you have an N2 disease. So this is what we are talking about, locally advanced. You've given neoadjuvant chemotherapy. Response rates are about 5 to 6%. I mean, you get a good response, but complete response rates are about 5 to 6% with chemo. Immunotherapy is slightly being higher. But the problem is, with non-invasive methods, whatever you do post-neoadjuvant chemotherapy, the accuracy is very low. And false positive rates are very high in our country, so it's very difficult. So restaging is something which we should definitely consider, but after that, I do not know what to do. So re-mediastinoscopy is actually possible with lower and is possible, but the accuracy rate is slightly lower, morbidity is slightly higher. So once you have already done a mediastinoscopy for staging and you want to do a re-mediastinoscopy, it's going to be a problem. So it's very selectively performed. My choice would be to do an endobronchial FNAC stage, and nowadays that is the standard of care. There's undoubtedly that we are not going, the mediastinoscopes have actually gone down drastically, and then EBUS, induction, and then do a first time mediastinoscopy to make sure that you're dealing with persistent N2, and also you're also ruling out an N3 disease where your surgery would be futile. Okay, but if it comes positive, let's say persistent N2, what should we do? We don't have an answer. So even at this stage, as of now, we continue to go ahead and surgery try and clear because that's slightly better than giving radical CTRT as long as you're going to do only a lobectomy. But again, the evidence is not very strong. Okay, so downstaging, this has been discussed. I'll not get into it, but it actually causes downstaging of both nodal as well as primary tumor. Path response rates vary anytime, and definitely it is associated with better overall survival. So the interesting thing is, for those who are inoperable or deemed inoperable, the extent of surgery can come down in about 30% and they be higher R0 resection rates. So these are, what are the challenges after immunotherapy? I've taken the liberty of adding on one slide to what immunotherapy does, because the common notion is, yes, it does cause a lot of fibrosis. We may not be able to offer surgery after immunotherapy. No, that's not the dictum. So it depends on where exactly your nodes were present. If you have a bulky hilar nodes, yes, it does cause fibrosis. The only thing is you may not be able to do it minimal invasive, but you will be able to do it by open, and doing an open surgery is not inferior to, if you're not able to do minimal invasive, don't lose, but still surgery has a role to play. So there are multiple prospective studies which have actually looked at the safety of performing after neoadjuvant immunotherapy. Only thing is the conversion rates are higher from VATS. That's the only thing. Maybe the conversion rates about 15 to 20% in high volume centers, but immunotherapy, it may slightly go up. But resection rates and R0 rates have never been inferior or not inferior to chemo when you consider neoadjuvant chemotherapy alone. So in a locally advanced, when would I do an upfront surgery? When you have a single station node or nodes less than 3 centimeters, lobectomy, rather than when I know that I'm going to do a pneumonectomy, I would definitely do, and also response to induction therapy. So these are some of the options that we have, which has already been discussed, so I will not get. So I am a strong proponent of neoadjuvant therapy, be it neoadjuvant chemo, neoadjuvant chemo immuno, or in certain situations, even neoadjuvant chemo radiotherapy too, especially for the pancreas tumors. Because that is also an area of concern, because radiotherapy is going to increase your chance of morbidity. Actually, it does not, unless and until you have your central lesion, then the chance of morbidity is going to go high, and the dose of radiotherapy that you're delivering in the neoadjuvant doses does not cause. You can very well take care of the bronchial stump. The only problem is the bronchial stump that we have, and you can very well take care of the bronchial stump. So, this is a Zhang meta-analysis which has actually shown that if you have perioperative, it is better surgery, chemotherapy followed by surgery, and then does the best. I mean, you have bimodality or trimodality treatment. We know that the famous Kathy Albane trial showed an improvement in DFS receiving trimodality treatment. There was no improvement in overall survival. The main reason is majority of the patients underwent pneumonectomy. So this was an era where the sleeve resections were not performed much, and so that was one of the reasons why pneumonectomy has a mortality, and so that's why there was no difference in the overall survival. So forest plot, most of them favor surgery, so I would still say that surgery remains a better modality when compared to radiotherapy in the neoadjuvant era. So chemoradiotherapy versus chemotherapy for surgeons, it's like both or less. I agree that it may be challenging in terms of you have more additions, but it is not impossible. The morbidity profile is also remains the same. And only thing is the chances of bronchial blowout, which is just one extra morbidity, that which actually is higher with neoadjuvant chemotherapy. Now coming on to extent of surgery, the standard surgery remains lobectomy with systematic mediastinal lymph node dissection in post-neoadjuvant era. The other surgeries that are actually performed are a pneumonectomy, or you have a bilobectomies, or you have a sleeve resections. So sleeve resections can be in the form of an upper lobe sleeve, or it can be in the form of a carinal pneumonectomy. So these are some things that which can be performed even after neoadjuvant chemotherapy. Role of segmentectomy in a patient post-neoadjuvant is not the standard of care as of today. In early lesions, it may be considered, but as of today, role of segmentectomy is not the right choice. So pneumonectomy, is it contraindicated in lung cancer or in locally advanced? No, it is not contraindicated, but definitely rates are declining. 30% of the times, patient who requires a pneumonectomy, you're able to get away with a lobectomy, either in the form of a sleeve lobectomy or in the form of just a lobectomy. So yes, is it contraindicated? No. It is indicated in patients, young patients who are actually with a very good cardiopulmonary reserve. Most common indications are you have a central tumor, you have invasion of the pulmonary vasculature or the bronchus, and if there are synchronous lesions in the other lobe. Even the synchronous lesions in the other lobe, we would actually do a lobectomy with a segmentectomy of the other lesion. It's something that would be better than doing a pneumonectomy. And otherwise, if you have a fissure, transfissuration. So the 5-year survival rate following pneumonectomy can be as high as 38%, which actually justifies the procedure. Is there an alternative? Yes. Sleeve lobectomies are an alternative procedures, but these are technically demanding, and they have shown 5-year survival rates better than pneumonectomies. And it is also shown that sleeve resections, mortality and morbidity is also much less when compared to pneumonectomies. So these are some of the data which have actually come up comparing between, there are no randomized control trials, there are only prospective propensity match studies. They've shown that quality of life is also much better with segmented sleeve resections. So it's favored over pneumonectomy. And extended resections. Can I go ahead and do extended resections following neoadjuvant chemotherapy? Yes. The long-term survival for these patients vary between 46 to around even close to 60, 70% also for some of them. But mind you, they has to be N0 or N1. There is no point attempting extended resections in N2 disease. Last 2 minutes, please. So the best surgical candidate will be without lymph nodes. Where all can I extend my boundaries beyond the lobes? I could go ahead and resect the superior vena cava. I could do an atrial resection. I could do an arch of aorta or the ascending aorta, the chest wall, vertebra. These are some things that which are limited. So these are some of the patients where you've actually done, and then you can fix the spine doing a vertebral body resection along with spine. So you can resect up to 2 to 3 vertebra safely, and then but fine. But you need a good multidisciplinary team to actually go ahead and do vertebrectomy with spinal resections. So to conclude, surgery after neoadjuvant chemo or chemoimmuno is safe. Even chemoradiotherapy also could be done, but the incidences, the experience by most of us following chemoradiotherapy is very limited and is indicated only in Pancoast tumors as of today. So it does improve survival. Minimal invasive surgery can be done safely with equivalent outcomes only, but be prepared for conversion. Lobectomy remains a standard of care. However, pneumonectomy in carefully selected patients population also improves outcomes. So one size does not fit all. Personalizing surgery is very important. Location, extent, patient's condition, surgical expertise, and local economics. So surgery needs to be tailored. And thank you, and I'll be happy to take questions.
So thank you so much. So any question from the house? So I have a couple of questions.
Yes.
So I have a final answer from a surgeon. Chemo versus chemo radiation. Any problem to a surgeon while operating?
Yeah, so that's what. So if it is a peripherally located tumor, I may have a little bit more blood loss because of adhesions, but there are no major problems.
So you would prefer only chemotherapy?
Yeah, as of today, I prefer, in a Pancoast tumor, I would prefer neoadjuvant chemoradiotherapy, but in others, I would prefer chemo because the outcomes are more or less similar between neoadjuvant chemo versus chemo-RT. But Pancoast tumors, NACT-RT, the outcomes are much better when compared to chemotherapy alone. So that's the only situation.
Pancoast, you will be happy giving
I will be
only
happy,
chemo.
yes.
The second question again, chemo versus chemo IO, because there are a lot of debates going on, the immuno causes this and that, and the delay and in the surgical planning of the treatment. So chemo versus chemo IO, a surgeon's perspective.
Chemoimmuno, if patient can afford, I don't see any problems operating following chemoimmunotherapy. As I said, you can do a good open surgery. So it's not mandatory that I have to do minimal invasive in all patients. If I will start off with minimal invasive, my conversion rates may be much higher, but that's okay. Or doing an open surgery is not inferior.
And if the patient, suppose after N2 diseases, post-chemotherapy, there is a regression, are you still happy operating, or what are the borderline cases where you think I should not operate, let me give this case to a CTRT for, borderline cases where N2, even after response to the treatment, a surgeon is not very happy operating upon? Because we have cases, we have shown good response post-chemotherapy or CTRT, and my surgeon says, madam, please, I think it's better that you people continue with the therapy. I'm not happy operating upon. So what are those borderline cases? Yeah,
so one of those is, it's very important to read your scans. So if you have a plaque-like disease on N2, mainly, as I was discussing with Dr. Srinivas today morning, you have a plaque-like lesion on the N2 disease which was previously positive, and it remains to be positive. I don't have an answer. So these are some things at which I am not going to get an R0 resection. If I am not going to get an R0 resection, I might as well treat this patient with concurrent chemoradiotherapy rather than having an R+ resection and then giving adjuvant radiotherapy. Because adjuvant, they will fail. So I would prefer, giving concurrent chemoradiotherapy and then follow it up with the durvalumab, which has better outcomes. I know there is no comparator. There is no comparator arm, but if you ask me at a personal note, I would definitely treat these patients with radical CTRT and then give durvalumab. They may have better survival. Unfortunately, even if the Pacific trial did not show how many patients they underwent salvage after CTRT, the data is not available. And why they never considered salvage is also a query question mark in the Pacific trial. So this is one. So central tumors are not an absolute contraindication. It is purely expertise. If I have a lesion sitting on the main pulmonary artery, Yes, you can even actually do vascular sleeves. It's not only bronchial sleeves, you could also do vascular sleeves, and vascular sleeves are also safe. But you need to read and understand whether you will be able to anastomose. And as I said, if it requires a pneumonectomy, intracardiac, you could take the vessels intrapericardiac. The main pulmonary artery pericardium can be opened, and you can take along with the pericardium, and you could still go ahead and do a pneumonectomy. But that is, your patient should be extremely fit. Otherwise, go with CTRT, and which will do a better job than the knife.
Correct. Last week we had a case. The surgeon did a heroic surgery, perfect, but the patient general condition did not allow us to give adjuvant where she was a fit candidate that she should have received. So there should be a MTD, a tumor board's discussion between the surgeon and the medical and the radiation oncologist whether we should or not. Just performing surgery does not suffice. Patients should be fit to receive adjuvant. Then only that makes a sense.
Otherwise, I should not, as you rightly said, after surgery, I should not make him a cripple and then send to you and say, now you do the rewiring. I don't think that's correct. I may be able to resect, but it might not be helpful for the patient.
Correct. So this is a very important thing that, that all the teamwork should sit together and then decide. So thank you so much.
Thank you.
Wonderful presentation. Yes, yeah.
Okay, so the standard remains lobectomy. I agree that you're bringing out into a topic, why not do a segment, why not do wedge resections? See, even in early lung cancer, if you see, segmentectomies are recommended with only 1A tumors with a consolidated CTC tumor of less than 0.5. So you're not going to offer segmentectomies even in early lung cancer. So in that case, I wouldn't recommend doing segmentectomy for a patient who has undergone neoadjuvant chemotherapy. So lobectomy still remains the standard of care, and I don't think, we may come up with a trial later, but that scenario is going to be really, really less. And the other question you may ask, now that the patient has developed PATCR, can I treat the patient with radical CTRT? It's going to be an, evidence-less debate. So it's on the if the patient is fit to undergo surgery, I would. If not, then probably, and if you can do an SBRT, if you have marked a clip, I think we should be looking at future, with the in the era of immunotherapy, like how we go for breast, we put clips and try to take out those small ones there. I think that should be the future of in the era of immunotherapy. Slide to mark with some fiducials inside the lung, and just go try and do that, or do SBRT to that area, and then say, okay, I'm preserving pulmonary function to a larger extent. That should be the future, and that will be the future in 10 years down the line.
Thank you.
Thank you.